My name is Scott Cavanaugh. This is my senior project presentation. I have joining me today fellow co-workers. I have Kelly.
Hello.
Rachel.
Hey.
Amanda.
Hi.
And another Kelly.
Hello.
Thank you all for taking part. My project goes over guidelines for reducing hospital admissions. All of us work in the hospital, so we can all identify with this particular project in some manner. The abstract for my presentation focuses on the growing importance of hospital readmissions and why we need measures to reduce those, right? They should be in place because we have financial ramifications that could potentially be very steep for the organization. My project objectives and rationales will be defined to give you a definition and also provide clarity and root causes of this particular problem as well. Evidentiary research will be cited just to substantiate the need for a change in any current processes that we have. And then at the end, we'll talk about why there should be an evaluation process to see where we are once the project was implemented. You can follow along in your packets that are provided to you if you like. That will be helpful. So first, let's talk about what is a hospital readmission? What constitutes a hospital readmission? Does anybody know what the criteria for that is concerning Medicaid and Medicare services or how it applies to a hospital? Does anybody know what that is? Good. I'm glad that you asked. It counts as anything that is an unplanned admission that happens within 30 days. That does not necessarily have to be disease specific either. It can be any patient that's readmitted to the same hospital within 30 days. Okay? Readmissions to any acute care hospital are counted no matter the diagnosis, and measures don't include planned readmissions. So you see the difference there. There's a difference between a readmit and a planned readmission. So, for example, if we have a patient that's diagnosed with lung cancer, has to come back for surgery, then that will be a planned admission. So that does not count against the readmission for that hospital. The cost of readmissions to the health system is substantial, accounting for over $17 billion just for Medicare. I would agree, and I think you would too, that is pretty alarming considering that we all are in healthcare and we need to grasp every dollar this day and time. There's also a notion that readmissions are tied to the quality of care, and I think you guys would understand how sometimes a readmission might look like we didn't do our job when we're here. If organizations can implement effective and sustainable measures to reduce the readmissions with multi-component interventions, then research suggests an increased likelihood for optimal patient outcomes and lower cost of care. After all, in healthcare, that's what we're here is for a good patient outcome, right? So, two things I want to say about that statement is sustainable measures. Sustainable meaning it needs to be implementations that are that the organization is going to be able to continue and carry on. The second word I want to talk about is multi-component interventions. So when we talk about interventions as it relates to admissions, if at post-discharge we're talking about callbacks, multi-component means is it one callback? Is it 48 hours? Is it then a week? Is it then 10 days, 14 days, 30 days? That's what's considered multi-component. Root causes. So let's talk about root causes. What do you guys think constitutes a readmission for our hospital? What are some things that you want to just throw out?
Probably non-compliance.
Non-compliance is one that's huge.
People having the funds to purchase medications.
Yep. Patient resources such as medications, transportation, finances, insurance, family and or friend support. Right, because it's always better if you have somebody that can coach you along once you're gone. Anything else?
Education.
Education is huge. There may be a lack of understanding, and that can be demographic specific, in populations that are very uneducated, but that can also extend to your older patients who may not understand just because they're a little bit older and grasping concepts are a little bit more difficult at that time. As well, the ones we've already mentioned are big, but also untimely or no follow-up provided. So we discharge them from the hospital and then that's it, right? So in a couple of days when you've discharged a patient with COPD, they get a little shorter breath, they're coming right back. But we need to bridge the gap to have them go, say, an outpatient center, be it a primary care provider, a community clinic of some sort that keeps them and is focused on keeping them out of the hospital. And then you might just have a lack of a primary care provider, period. A lot of patients, depending on demographics as well, don't have that available to them, be it resources, be it that they can't get in a timely manner, or they just don't have one, period, for whatever reason. So let's talk about, this slide talks about just different factors and who's responsible for what. So we've already discussed a few patient factors, education, lack of understanding, resources, that kind of thing. What are some factors, say, for the hospital that is untoward for our readmission rate? What are some things we're doing that don't promote a good transition for the patient?
Could be lack of education.
Quality. Could be workload on the floor that don't have time to do the intensive discharge like it takes for some people. What about complications of care? Like, to me, there are certain disease processes that are going to come back. Like, we're not going to prevent every one, but there are those key ones out there that we can identify and we can put measures in place. Your chronic COPD, your heart failures, people like that, MIs. Those can be forecasted. What about things in the community that are factors that don't lend to a transition outside of the hospital for aiding in not coming back to the hospital for readmission?
Well, for those with no insurance, proper care outside of the hospital.
Yep. Transportation is huge. And I think just overall a lack of concern from the community. In some areas where readmission rates are high and populations are very diverse, you don't necessarily have buy-in and support from community, so that's certainly a factor. And then there are social factors, right? We've already talked a little bit about that, and that can be from lack of resources again, lack of support, be it family, friends, significant others, whatever, to help coach us along, remind us of things, appointments, taking medications, going to get refills, going to the doctor, things like that are certainly big as well. So my objectives through this project, we have to know why we're doing what we're doing. So my objectives are to bring evidentiary research to the forefront on this topic to assist administrators, clinicians, and others on the reasons why we should have a highly structured process to reduce our readmissions. As well, I want to express the quality of care and patient outcome is the primary concern. I don't want to convey that we just do this for the money, right? Because quality of care and patient outcome should always be of utmost concern in my opinion. And then I want to share interventional components to demonstrate the proven manner in which such interventions have been successful in other organizations and based on research. Why would we do this? So, as we discussed earlier, it's relevant to all healthcare. It's not just my organization, your organization, it's across the world, right? Across the United States and beyond, because this is something that's being managed worldwide. And then given the potential financial ramifications, I would think that organizations would want a very lofty interest in establishing these guidelines and measures to reduce the rates. So that's why we present such a project. The next, we need a question, and the question that I've put together that covers the components needed for any project. So it identifies the problem, the patient, and the population, any interventions or indicators, comparison, and an outcome. And my question is simply, how do multi-component interventions and guidelines, including pre-discharge interventions, post-discharge interventions, and bridging interventions reduce hospital readmissions, including quality of care and cost of care, as compared to our current guidelines and interventions. So most organizations probably have some sort of process in place. It may not be very aggressive. So this question helps us identify what are we currently doing, and if we were to do this with this patient population, where would we be? To present any evidence, I have three things to present as part of my research for this project. The first piece is the study was an analysis of publicly reported hospital readmissions reduction program and the data that examined the effects of that program on reducing the hospital readmissions. The study included short-term acute care hospitals in the United States, and the outcome demonstrated a marked decrease. So just to give you a little background, the hospital readmissions reduction program is the program they use to penalize the hospital for their readmissions monetarily. And there are several factors that go into that, but for example, if the readmission cost the hospital reported at $10,000, then they could take a 1% reduction. So you do the math, that's $100, and depending on your bed size in the hospital and how many patients you service a day, those $100 add up super quick, especially over a year's time for, when you consider the fiscal year. And then the effects of the reduction program, they were greater in small hospitals, public hospitals, and hospitals in rural areas. And why would you think that is?
Income or
Right.
education?
Right. Those places tend to have less resources, less support. So you would see a greater effect in those type of areas. The second research study, it was a pilot test, and it tested the feasibility of the primary effects of an intervention. And in this case, the intervention was a community health worker who was put in place to help reduce their readmissions. It studied medical service patients that had a primary care physician who were discharged to home, and they had risk factors that kind of pointed them that they would be potential for readmission. Roughly 70% of the patients received at least one post-discharge call within initially, and then 38% of those received 4 calls. So over that 30 days, they received 4 calls versus just 1. And as you can see, the outcome shows that the readmission rates were lower among those patients that were actually called, that had somebody checking in on them. So that's from an intervention standpoint. And then the third piece was a study that evaluated the identification of potentially preventable hospital readmissions by using results based on administrative data that was put together. It was a random sample of 455 readmissions in a Dutch university hospital, and reviewing the medical records of those readmissions resulted in 28.5% of those records being classified as potentially preventable. So almost 30% of those readmissions out of 455 potentially were identified as being preventable. So that statistic is pretty alarming as well, because it could very well be the case for our organization as well. How will this change affect me? So any of us that work in healthcare, you always want to know, how's the change going to affect me? And not necessarily from a selfish perspective, at least in this case, but how's it going to affect the way that I care, provide care, communicate, things of that nature. So as part of the healthcare team, for me, I consider myself a steward of our patients and their care. They're not just here, I'm not just here. I'm here to do a job, a calling, if you will. It offers a sense of satisfaction for optimizing patient quality of care, coupled with satisfactory patient outcomes. Like, I'm happy to be a part of, for the good, changing an outcome for the patient. It gives an individual contribution in participating in the organization's financial and quality goals. In most organizations, all of their employees are held to that standard anyway. Another thing is it makes me feel like I'm part of the solution and not part of the problem. Like, I'm trying to help this solution rather than being part of a problem, which may include, I don't have time to educate this patient. And then it's the right thing to do for the patient. How many times have you heard that? It's the right thing to do for the patient because it does affect their care and their outcome. So recommendations. The first would be to bring awareness of the necessity to those key people in the hospital. Those key people would include senior level leadership, key clinicians. You need doctor buy-in, you need nurse buy-in, but they're the ones that are actively carrying out the care. And then other support staff. Support staff can be another discipline of some sort. It might also be the staff of a unit secretary who does help bridge the gap with such things as follow-up appointments or records to an office, that type of thing. The other thing is they must see the need. If we don't see the need in this, it is not going to move forward. So we have to do a very good job of educating and then bringing awareness of why we should make the change. We would need to present evidentiary research that demonstrates these effects and standard measures. That gives us sort of a leg to stand on, gives us some credibility when we present those things and they can see the actual effects and how it impacts. Financial comparisons of a cost of care on readmissions to the healthcare organization. If you want to talk to anybody in the hospital and make them happy, you can talk to them about how things like this can impact their financials, be it negative or positive. In this way, we want to move towards a more positive shift. I would create a resource team made up of those key people we talked about earlier from the very get-go before we even launch this project. I would establish that resource team, which may look like the launch team. And again, for bringing awareness, education, deriving evidence-based interventions that are unique to the organization. I want to stop there for just a second. What works for one organization may not work for another organization because we all serve a different population. Some organizations be profit, some might be not-for-profit. So I say what works for us. I don't think we should necessarily adapt our process to what is working well for somebody who's not even like us. So in a sense, I'm just saying compare apples to apples. Interventions that should be focused on should be put into three categories: pre-discharge, post-discharge, and then what are we doing to bridge, right? And we'll talk a little bit about that later. All the revisions, major and minor, I would recommend that they be approved through a process improvement team as to not have just random changes made. It keeps us standard and it keeps us accountable, and then it actually runs through a process improvement measure. Implementation of multi-component interventions that are best practice. So we want to know things that are tried and true if we're going to go on this venture. And then establish an escalation process that goes to the resource team should issues or questions arise, which doesn't leave people hanging. It doesn't leave employees hanging. If we implement this new process, they have somewhere to go that's always available that may or may not include somebody who is less accessible to the staff, administration, people like that. This is where I want to stop and talk just a little bit about breaking our interventions up into pre-discharge, post-discharge, and then the bridging interventions. So before we look at this slide and talk about exactly what's on here, when you think of discharging a patient, what do you think of some things that while they're in the hospital, which is the pre-discharge period, that we could identify as soon as they come in the door?
If they have a primary care physician.
That would be one. Do they even have one?
What needs they might have to purchase equipment, medications after discharge.
That'd be the equipment. What do they need? What would they need going home?
Primary caregiver who's going to take care of them once they leave.
Yep.
Transportation.
What do things look like at home? Are you going home? What do we need to plan for? A lot of times you have patients that come in with a family member that says, I just can't take care of them anymore. In a pre-discharge, measure in your mind, you think, okay, we need to be looking for a place to put this patient, right? So just as many as you all said, in the pre-discharge, we can talk about new or established primary care provider. Y'all said that they didn't have a doctor. Well, we can help bridge that, right there in the hospital. And then identify the needs. And then a big thing is disposition. Where are we going? So as much as we can do up front, because we all learned in nursing school that discharge begins on admission. The second component is post-discharge. What do we do post-discharge? What are things that take place post-discharge? Like they're gone from the hospital, what are we doing?
Follow-up phone call.
Sending records to primary care.
scheduling tests that were maybe from the weekend that weren't scheduled while they were here.
So we're kind of following through on things. This post-discharge is a huge piece where the ball gets dropped a lot, because a lot of people think out of sight, out of mind, nothing's left to do. And so this project presents why post-discharge is essentially more important than even while they're here when it comes to discharge. Bridging interventions, I like to consider those as like the safety net. So like anything we haven't considered pre-discharge or post-discharge, right? So anything that bridges that gap. It might be, going above and beyond to make sure the patient gets to their primary care doctor, or anything that we bridge that gap. Because these are the pre-discharge and the post-discharge, they're kind of single units that operate by themselves, and the bridge is more a collaborative effort that we are bridging that gap from any element of discharge to their next follow-up, etc. How do we evaluate the project? So in order to know if anything's effective, you have to measure, right? You have to evaluate it to see. So initially, I would recommend that there be continuous evaluations until the organization establishes a rhythm based on its solid process now. So, give it some time to get up and running, implementation to be put in place, and then let's evaluate and see where we're at. Once that's established, then we could move to a quarterly basis. Once we get a good solidified process, we might evaluate every quarter to see, are we on target? Do we need to change anything? That type of thing. And then I would suggest that they be tied to the organization's quarterly strategic goals. That's in an effort to keep it at the forefront for everyone across the continuum, everybody in the organization, because it should be important to them. It offers quality and patient outcomes, so it definitely should be seen across the organization often. So quarterly is usually when those goals come out. And then we would need measured data to determine what our prior readmission rates look like and what they look like now after we've implemented these processes and interventions. As well, not just on the readmission rate, you may want to consider your quality indicators. What do those look like pre and then post implementation? And then the good news is, once the benefits of implementation can be proven through either a reduction of cost or a reduction in the readmission, then success can be realized. And it may be both. It'll be the best case scenario. But I also wanted to notate that if it's one or the other, that's still a success. Anytime we're moving forward in a different direction than we were. And then a continual process improvement will be necessary to stay current with any changes, be it local or national. I say local because that applies to us. National, we might have other guidelines that come down from Centers for Medicaid and Medicare Services that we need to go by. And they may require revision if at any time we see this is not effective, and again, based on a negative shift in the results. What would I expect to happen out of this proposed project? Well, the first thing is, I would think with all the education and research, an increased awareness, a recognition of why we need the change, a formation of a task force and or a resource team, and then I would expect there to be research development to prove effectiveness of evidence-based guidelines. And then I would expect implementation of proven guidelines that impact the quality of care, the readmission rate, and then the cost of care as well. And these should be organization specific again, because every organization is not alike. And then I would expect us to see a reduction in readmission rates, leading to more effective quality of care and an optimal patient outcome. And that might be slow at first, right? Till we get a rhythm of why we're doing what we're doing and how we're doing it. So it may start out, minimal, but then I would expect it to graduate to a higher level. And then overall, a successful project. So in conclusion, this project presentation is an initiative to bring about awareness, education, and action concerning the ongoing initiative of reducing readmission rates, with the potential financial ramifications now and in the future, because I think it will perpetuate through the years. and only increase in intensity. It's a topic that we should put priority on, not just again for the financial piece of it, but for quality of care and for patient outcomes. And then expedient implementation of evidence-based intervention should take place in an effort. It's not something that I feel like an organization should sit around on very long. Do the research, get moving, get things implemented. Evaluations should be ongoing to realize any measured success. Significant benefits should be realized if the organization takes seriously the need for such change to take place. Our quality of care and its effect on patient care should be why we do what we do. And I think this project would impact both of those things. So, are there any questions? Anybody? All right.
I think it's very informative.
It is.
Thank you all for being a part of my presentation.